Hello, everybody. My name is Christine Owens, and I'm a Temple student, and I'm also part of the Wellness Resource Center. I'm a member of Students for Sensible Drug Policy here on campus, and I'm also a Pure Diamond student teacher with Dr. Deirdre Dingman in her class, Substance Use in Society. So today we're going to be talking about harm reduction, and I have with me Jonathan Larsen from Temple Center for Public Health Law Research, and I'm going to let him introduce himself.
Thanks so much, Christine. Again, I'm John Larsen. I'm the legal technology manager here at the Center for Public Health Law Research at Beasley School of Law. And what we do at the center is something called legal epidemiology. So it's the study of law as a factor in health outcomes, essentially. And we use a specific tool called policy surveillance that allows us to systematically review the law to understand what it does and to create high quality legal data that people can use to see whether or not the law is working or not. So what are the health outcome changes that we're looking at? A lot of my research focuses on drug policy. I've done a lot of research recently on the opioid settlement litigation proceeds. I'm working with a team, transdisciplinary team across the state with folks at Penn State University and Pitt, working with the PA Opioid Trust and looking at transparency around that. But today we're focused on harm reduction. We're focused on the ever consistent balancing act that has occurred in the United States since the war on drugs was launched in the 70s. And the war on drugs has really set the tone of how different levels of government respond to substance use disorder, opioid use disorder, all kinds of drug policy is dictated by this overarching response. And we like to think of this at the center from a whole of government perspective, where you have federal policy, you have state policy, you have local policy, and many times they are counteracting the end goal. They're not aligned to, say, increase harm reduction activities. And just to take a step back for a second, let's define some terms. So harm reduction in context of the opioid crisis is focused on preventing overdose and infectious disease transmission by working with people who use drugs without moral judgment. And that's really important. So we want to be starting from a place where we're not judging the drug use itself as a driver for what kind of services people should have access to. And the law is really important in all of this because the law sets up the structure that provides that access to potential harm reduction treatment. That could be needle exchange, that could be access to recovery supports, but ultimately, in that context, we have seen in this country a hyper focus on criminalization, which has caused stigma. So folks are less likely to access supports that exist, including treatment for opioid use disorder. So
yeah. We also, and I think this is from the war on drugs, we have a hyper focus on abstinence only. And that's something that the majority of the policies from the war on drugs are guided by, an abstinence only policy. And that's something that I love about harm reduction, because harm reduction wants to acknowledge the health and the humanity within a person, even if they're not willing or ready for abstinence. And that's sometimes where the law can get in the way, because the law is set up for us to kind of not be able to help people until they're 100% willing to reach abstinence. And you were mentioning treatment, and sometimes that even this abstinence only ideology gets in the way of like medication used as treatment, like methadone and Suboxone. Um, but
The,
yeah,
the legal structure that has been effectuated in this country leads us to a situation where only 1 in 5 people who are eligible for treatment for opioid use disorder are actually accessing it. And we have 3 really good options. Buprenorphine, uh, is available. It's a gold standard in care. You could get it at your pharmacy. There are certainly some issues that exist with pharmacy access and things like that. Um, but that's one piece of the puzzle, and there are many moving parts here. Um, when we think about barriers to harm reduction, and I go back, so I started talking about criminalization in broad sweeping terms. Well, what does that look like? So we have drug paraphernalia laws that criminalize a whole bunch of different things that could be related to drug use. This could be syringes, access to syringes, um, pipes, other kinds of paraphernalia. Um, but in that context, it can be very limiting. So, in the state of Pennsylvania, as an example, drug paraphernalia laws apply to syringes. Now, that's at the state level. Um, when we think about local control, we have authorized syringe service programs, needle exchanges in Pittsburgh and Philadelphia. So right now we have Prevention Point Philadelphia that provides needle exchange and other services, comprehensive services around substance use disorder. That's really, really important, but it's not broadly accessible in other areas of Pennsylvania. So that kind of causes a situation where there's you know a point of care in cities, but then you have rural areas with this same kind of substance use disorder issues that just don't have access to that kind of harm reduction, capacity building, and that's a big problem. I start to talk about some other things in relation to what we've learned at the center around the legal landscape, where we've looked at um, really what are the barriers that exist now? How can we address some of those challenges right now? And when we think about it, a lot of the legal structures that exist, like Good Samaritan laws, so the ability for you to call 911 to have a first responder come if you have been using drugs with friends, uh, and to have that situation handled in a way where you prioritize an overdose and saving that person with Narcan, um, and not having to worry about being
being arrested
arrested,
for possession, and yeah,
possession, or having drugs in the vicinity, things like that. And that kind of law only exists because we have such a onerous criminalization standard as the guiding force.
right.
That's kind of linking everything together. So there are Good Samaritan laws in almost every state uh, right now, uh, but it is more indicative of the criminalization than of a solution. So you now need Good Samaritan laws in order to give folks
Right.
extra coverage to do something that should be a
That's like
national,
morally obvious.
a
Yeah,
morally obvious response to save someone's life.
right.
the judgment that falls into the criminalization paradigm and the stigma paradigm is that someone that's using is somehow less deserving of some of these services, and that's something that the law has the ability to to impact and potentially change in a better way. But we need a response that takes into account all of these different parts where there are so many different countervailing responses. So, like the federal government, as an example, won't pay for syringes. So that's a problem in a funding train. Then you need state, funding. You need local funding to even pay for the syringes that would be available at a syringe exchange.
And that's interesting that they don't, because they do publish multiple peer-reviewed journal articles on their websites on like SAMHSA
Yeah,
and NIDA, stating that syringe exchange programs do work. So they openly acknowledge, like the scientists and researchers openly acknowledge that these programs work, but then they won't support them.
the legal reality is linking back to another moral judgment that's being made about what should be paid for, what shouldn't be
Yeah.
paid for, and that's causing this friction that needs to be worked out of the system. And there are many different ways to address that.
Like what?
But good question. So it comes down to local advocacy. It comes down to, well, what is in control of Philadelphia government versus state government versus federal government, where they can take different actions. The needle exchange prevention point, Philadelphia is a perfect example of that, right? Where there's an opportunity, there's a need, there's a public health imperative to stop the spread of infectious disease. In this instance, it was directly related to the spread of HIV.
Right.
And just like you said, there is heavy empirical evidence that this is needed, that this works. Clean syringes reduce the spread of disease when the alternative to that is needle sharing and potentially spreading infectious disease more broadly. So when there are those kind of opportunities, they need to be taken advantage of and implemented like they are in Pittsburgh and Philadelphia, because that causes then disparities in other parts of the state where those kind of programs aren't available.
I can imagine that, because I know that sometimes people from the suburbs, they come to Philadelphia to purchase their drugs, and I know that they sometimes use prevention point, and I'm curious about the legality of that. Like once they cross that city line, if they, if they're more at risk than if they hadn't crossed the city line, I guess I should say. I don't know
Yeah.
if you're
And
familiar with that.
when they're in Philadelphia using those services, that's protected. That's part of the executive order. That was the original impetus for that in Pittsburgh, as an example. There's a city ordinance from 2008 that authorized their syringe service program to operate. But you're right. The stigma and the fear of enforcement of, am I traveling with needles in my car? Am I going to get pulled over
Right.
uh, and charged with some type of paraphernalia? Possession of these materials that are hypercriminalized. This goes into another issue where in the state of Pennsylvania, we're very familiar in the harm reduction space now with drug testing, right? We've talked about fentanyl, different adulterants that have gotten into the drug supply that make using drugs
Right.
much more dangerous. Individual users can protect themselves by testing. And then there was the issue that existed with the drug paraphernalia law, where before, uh, you know, uh, before they changed the law relatively recently to include drug checking equipment, um, it was potentially a situation where that you there was some illegality attached to testing itself, to the materials used in testing, and that's something that needs to be addressed through legal means to remove that from drug paraphernalia law whenever possible, and to use broad language that covers more drug checking material uh, than something very specific. So if the law simply removed fentanyl test strips, well, that's one piece.
Right,
But what about other adulterants that are coming in? Because we know
exactly.
there's constant churn in the drug supply. This is where the law becomes really, really important in making those carve outs to protect folks who are using, and to not have that moral judgment and stigma attached to that situation. So that's one example in Pennsylvania, at least, of positive change, and we track that at the center, where over the last several years of increasing concern about fentanyl, and then xylazine and other kind of
And now
adulterants.
it's medetomidine, and it's
Um,
just going to keep
it,
changing.
it will
And
continue to cycle,
yeah,
and we need to be the law needs to be flexible enough to um, anticipate those kind of changes, so that we're not criminalizing some type of testing that could be occurring
I
uh,
agree.
without thinking about it. So we have seen a trend, though, over the last several years from the center's research, that more and more states are attempting to acknowledge first fentanyl test strips, but then drug checking more broadly, and more states are continuing to pass laws that uh, that remove drug testing specifically from drug paraphernalia laws.
Right. Yeah, it feels like we tend to wait until a bunch of people die and then hurry up and pass like a quick law to try to protect some people. And then by the time we do, there's a whole nother new thing on the horizon. And it feels like we need to sit down and pass some laws and create some policy that envisions, the whole scope of things, like you were saying.
This is where I certainly can share resources afterwards that can link to some of the work that the center has done around looking at the whole of government approach, what kind of actions can be taken now by state legislatures, things that individuals could choose to advocate for that would uh, get rid of some of the existing uh, sand in the gears, these problems that we talked about, where maybe the federal government's not allowed to fund something, or there's a federal law like the federal crack house statute that really has caused major problems in implementing safe injection sites. So outside the context of a needle exchange, the idea that acknowledging that people are using, and that if they did it in a safe space, they had access to needles, that's a different, slightly different paradigm, but from a harm reduction perspective, would be really, really helpful. And we've had states authorize now uh, uh, safe injection sites. Uh, at least beginning to, and there are a couple that are functioning now in New York City, that are a good model for how that could work. But it comes down to the local level doing things that at the higher levels of government are still in this flux, there's too much focus on criminalization, and that's where looking at a whole of government approach to how do we change each lever that is maybe turned in the wrong direction. There's
Right.
something that's counteracting what we need to do. And one of the main things that I want to emphasize here is that there's been an issue really in defining what the problem is. And that goes back to the idea that if we overemphasize criminalization as the mechanism of fixing a problem, that's taking away from the treatment paradigm or looking at things from a different perspective where we value the healthcare aspect of getting folks to the treatment that they need or the safe or the clean needles that they need now, um, over the idea that using the drugs is so repulsive
That they
to
just deserve what they get.
that that
Yes.
that drives a stigma and kind of diminishes all of the other healthcare responses because folks will be less likely to try to even access the care that they need if it's not seen. And it goes back to the point that you were making earlier about people going across from different counties coming to Philadelphia. Well, Philadelphia acknowledged a problem, tried to address it in a way that they had control over, which was setting up, Prevention Point Philadelphia, and they did it because there was, real. They were able to explain the need and explain the public health imperative, and that's not something that is easily done in maybe other contexts, in other political environments, in other places at the local level. Um, so that's something that has certainly crept into our understanding of the situation, that there are many things we know that can be done right now. And if there was political will, they would be effective. But the political will piece is really, really, really important, um, because you can't get the change you want unless there is the political will. And
And
that's,
the political will is something that um rides on like public narrative. Would you agree? I read something called like the Overton window, and it was talking about how policy isn't designed to change behaviors. Policy is designed based on what the public already thinks should happen. So, do you agree with the idea that if more regular folks were educated about harm reduction and educated about the damage that a lot of these policies has done, that we might get somewhere
yeah,
with politics?
yeah, there's definitely an element of messaging and figuring out uh, what that common narrative is. What is the normative structure? Again, if we take a step back to the criminalization, a lot of people agreed on that, and that's still the
Yes.
paradigm that drives the overarching narratives around drug policy response. It still links back to that, and that really is over. That's the harmful piece where to move it into a different context, because we think about this from different uh, overarching policy topic areas. So we looked at it from drug policing, from the treatment paradigm, from harm reduction as a major element, and social determinants of health. That's something we haven't talked about here. It's really not maybe going to be the main focus of what we talk about, but it's important to think about how do we address the underlying causes of the crisis, because putting people in jail is a punishment to act, the behaviors that they're exhibiting, and in this case, someone who's addicted to a substance, is addicted to a substance, that will be require some type of healthcare treatment,
Right.
um, response. So uh, there's a lot happening, um, in this space, and it's important to go back to what you were just talking about. So like what is the narrative that everyone is agreeing to with the problem? And if we're able to agree to more of a, well, what is our main imperative? Is it to reduce overdose deaths, reduce overdose itself, um, and to basically uh, help people uh, live a better life and link them to different care paradigms, that's probably a better core narrative than the criminalization narrative, which just hasn't worked. It
It
hasn't led
hasn't.
to uh, any kind of like, we've seen an unacceptable there's no number of deaths that are ever acceptable, but like we have just seen a constant curve. It's been going up, and even in the last year where we've had some modicum of
Right.
there's some areas it's gone down. um the baseline is so high that it's really the how we address the problem needs to change, and that's going back to harm reduction. We need a comprehensive harm reduction system that is not functioning on the fringes. It's not, it needs to be integrated into other communities. It shouldn't just be Prevention Point Philadelphia. There should be other opportunities for folks to access that kind of care in other areas. Um, and that requires, like you said, a different narrative.
Did things change when we got our new mayor in Philadelphia? I know that I believe it was Ed Rendell that made the original executive order about the prevention point being able to operate legally. But I thought I read somewhere that some things changed when her administration started. And
There was certainly the removal of the city funding directly to Prevention Point. That was one piece, um, but certainly there's concern around the prioritization of the public health response,
right.
and how that continues in a positive way. So this leads to just an obvious statement to make here is, if folks are interested in learning more, look up Prevention Point Philadelphia. There are a whole bunch of different ways for folks to be involved there, whether that's volunteering, donating materials that people might need. And then there's some other groups that are doing harm reduction right now on the ground, um, whether it's in Kensington or in other areas. There's a Soul Collective, SOL Collective, and there's also Community Action Relief Projects, CARP. So I just mentioned these things because there's a lot of activity that's happening. It's not just a needle exchange. There's on the ground, boots on the ground, people trying to help folks who are dealing with substance use disorder and opioid use disorder. And from our perch in Temple's law school, we are trying to better understand the legal landscape so that folks can really take action,
Without risking, yeah,
change change the legal landscape, to model after the places that have done things that are working. um, and that's work that we really feel passionate about, and will continue doing, to make sure uh, it's freely accessible to folks. People need this legal data, and we're going to keep doing that work.
and and it's important for anybody watching this to understand too. We were talking about narrative. And so even if you don't have the ability to donate time or socks or money or anything like that, just having conversations with people and making sure that we don't stigmatize people, that we use person first language, and that we understand what we're talking about, and we don't go around just believing things that you know, a war on drugs policy, we don't go around believing that stuff is works just because we were told it does. You're here telling us a lot of this stuff doesn't. You have the data that shows it. And I think that it's very important to me that anybody listening to this understands that and recognizes that we need a change. And the best way for change is for people to want that change. Hopefully we'll create law and policy that support that change. But you know, even understanding and believing in this matters as well. So
Yeah, I really appreciate that, Christine. And I will share the work that we did in the 84 different opportunities that can be taken at the federal, state, local level. It's good for folks to understand all of these different levers that really need to be switched. Because if we just do one thing on its own, it could be a silo and it could be blocked by something else.
right.
It's really the whole of government approach requires us to change how we're doing things so that everyone is kind of working in the same direction. And war on drugs, criminalization, use that model. People agreed on a direction, and the direction was criminalization as a means to a solution, which was to stop people from using drugs. But if we live in the reality of people are using drugs and we have ways to help people both through MOUD, through whether it's needle exchange for harm reduction, when people are using, um, those things need to be emphasized as not as part, not only part of the solution, but that's the solution to get to the
Right.
what we really want. It's not just stopping people from using drugs; it's to connect people to resources so they live their best possible lives.
In other words, it's not an opinion, it's data backed
Yeah.
facts. And this is a conversation I have with people sometimes, and they'll, you know, well, like, I don't agree with you. And I'm like, you don't have to agree, but a fact is a fact. It's kind of like the mask thing, you know, it's not about an idea or an opinion. It's about you have the numbers and the data that show what works and what doesn't. And we have these policies that are over 50 years old that have not been working, and we're still clinging to them. And I think it's great that we have the work that you're doing. I wasn't aware of this at all. Over here in public health, I didn't know that we had like a legal backing for all of this as well, you know, the data on the legality.
And I will also say in this forum that we do have uh, legal interns that come in every spring. We've already hired up for this spring, but anybody that is interested in doing this kind of work, like I explained earlier, policy surveillance work, where we're really trying to understand systematically scientific legal mapping. We use scientific method to understand what the law is, ask questions of the law, and then figure out, you know, what can change from there as this really helpful baseline. Um, really would love to meet folks that are interested in that.
All right. Well, thank you very much. And it was really nice to talk to you. And I'm glad we have this conversation. And I hope a lot of other people have the opportunity to listen to it. So,
Great to meet you, Christine. Yeah,
yeah,
have a great rest of your day.
you too.